So fetal growth restriction. Presenting a case of a female A, 24 years of age, housewife by occupation, her husband's name is B, living in Vadodara, has an income of rupees 3,000 per month, is Hindu by religion and of the upper lower class by modified Kupuswamy scale, came to the OBGYN OPD as a second gravida with 9 months of amenorrhea. Her gestational age, according to LMP, was 36 weeks 0 days, but on examination, her uterine height is less than the period of gestation. She does not have any history of pain in the abdomen, bleeding per vaginum or leaking per vaginum, any history of increased BP in the records, or headache, blurring of vision, or any pedal edema. There is no history of generalized weakness or breathlessness, and there is no history of raised blood sugar levels. Her menstrual history, she achieved her menarche at 13 years of age.
I'll just interrupt. Go back to your first slide. Yeah, this cannot be there. I mean, we all know that you are presenting a case of FGR, okay? But this cannot come in the presenting complaints because the patient doesn't know that her uterine height is less, right? So
Yes.
here you can simply say she was a second gravida, 9 months amenorrhea, LMP and POG is 36. You go with the rest of the things. So when something comes up, maybe you should come, right?
Yes, ma'am. Yes, ma'am. The negative history, then her menstrual history, her age at menarche was 13 years. Her past cycles were regular. There was no history of dysmenorrhea or heavy menstrual bleeding in the prior menstrual cycles. Her obstetric history, married life of 5 years, non-consanguineous. Obstetric index is G2P1L1. She has had presently a spontaneous conception, and at present she is 36 weeks 0 days by LMP. The previous pregnancy, G1, was a full-term normal delivery, delivered at the government hospital, was a male of 3 kg, was breastfed for 3 years. At present, the age is 15 months, and she was booked and immunized in the previous pregnancy, and the postpartum period was normal.
No, the baby was breastfed for 3 months and the age is 15 months. Something
3 months, I'm sorry, breastfed for,
probably. Okay.
Yeah. Past obstetric history, there is no history of preeclampsia or gestational diabetes mellitus in the previous pregnancy. There is no history of recurrent pregnancy losses, no history of antepartum hemorrhage in the previous pregnancy. There is no history of preterm birth or low birth weight in the previous pregnancy. There is no history of stillbirth in the previous pregnancy. And the interpregnancy interval is of 6 months from the delivery to the present concept.
Where is the history of current pregnancy, the trimester-wise
Yes,
history?
the next, present pregnancy.
No,
First
this should
trimester.
come first. This has to come first. So when you said amenorrhea of 9 months, LMP POG 36 weeks, you talk about the present pregnancy, then go to the past obstetric, then menstrual.
Yes, ma'am.
Yeah.
So the present pregnancy, first trimester, she has had a spontaneous conception. Pregnancy was detected with positive UPT at 15th day of missed period. She is sure of her dates. There is no history of folic acid supplementation preconceptionally. The patient was started on tablet folic acid, 1 tablet once a day. There is no history of nausea, vomiting, or weakness, or any urinary symptoms. There is no history of drug intake, no history of fever with rashes. The dating scan was done at 10 weeks using the crown rump length, and NT scan was done at 12 weeks and was within normal limits. In the second trimester, quickening was felt at 20 weeks of gestation. Patient was started on iron folic acid and calcium tablets prior. The patient was given 2 doses of TD vaccine 4 weeks apart, and the anomaly scan was done at 20 weeks and was found to be normal. In the third trimester, presently, the fetal movements are perceived by the patient. There is no history of leaking or bleeding per vaginum. There is no history of pain in the abdomen, headache, blurring of vision, or epigastric pain. Past history, there is no
second trimester history.
Yes.
Go back to the second trimester. So something's missing here. Important glucose tolerance test also we ask.
Glucose tolerance test,
Generally,
yes, ma'am.
patients are able to tell, the 5 things is quickening, iron folate, tetanus, anomaly scan, GTT. So these 5 you will generally ask in the second trimester from everyone. And in the next slide?
Third trimester.
Yeah, so blood pressure again becomes important here. Probably it is being monitored and the patient knows also. So blood pressure should be mentioned here.
Yes.
Okay.
Past history. There is no history of tuberculosis, epilepsy, asthma, or she is not a known case of diabetes, mellitus, or hypertension. There is no past history of any chronic kidney disease, and there is no history of any previous surgeries or blood transfusions. The family history, there is no family history of any congenital anomalies or twinning of hypertension, diabetes mellitus, tuberculosis, bleeding disorders, or any known genetic disorders. In the contraceptive history, there is no history of using any contraceptive methods. Personal history, her diet is mixed, her appetite is good, sleep is sound, bowel and bladder habits are regular, and there is no addiction noted. And in diet history, she has a mixed diet, including green leafy vegetables and eggs. But on a 24-hour recall method, the requirement is 2,400 kilocalories per day. Her consumption is 1,900 kilocalories per day with a deficit of 500. The proteins recommended is 78 grams per day. Her consumption is 45 grams per day. Her deficit is approximately 33. On general examination, the patient is conscious, oriented to time, place, and person. She is moderately built but poorly nourished. Her pulse is 84 per minute, regular with good volume. BP is 110 by 70 millimeters of mercury in right arm in supine position. Respiratory rate is 14 per minute, regular. And the temperature, she is afebrile. Her height is 157 centimeter. Her pre-pregnancy weight was 42 kgs. Present weight is 50 kg. Her weight gain at 36 weeks of gestation is 8 kgs. The BMI, according to pre-pregnancy weight, is 17 kg per meter square. So she is underweight. Yes, ma'am.
Yeah, Tejas, how can you explain to the residents how did you arrive at the recommended calories and protein?
Yes, ma'am.
Yeah.
Ma'am, we have used the ICMR. We have used the ICMR charts for the recommended calories and proteins in the case of pregnancy for this patient. And using that chart only, we have derived that for this gestational age, what should be the RDA per day requirement of calories and proteins.
So in general, we divide it like heavy worker or a moderate worker or a sedentary worker.
Yeah. So last year only probably new recommendations came, no? So all the students should please download that. It is freely downloadable from.
Your voice is breaking, sir. Actually, sir is traveling. He had some emergency at the hospital and will take a while to reach home. So we may have a breakage of connections. Okay, fine. So, yeah, where were we in the examination?
Yes, ma'am. So she is the last was BMI was 17 kg per meter square. Pallor is present in the lower palpable conjunctiva. There is no icterus, cyanosis, clubbing, edema, lymphadenopathy. The spine is normal and pedal edema is absent. In her head-to-toe examination, the head has normal shape, no frontal bossing. Hair has normal distribution. It's black in color. The scalp is dyed with dandruff, which is noted. The nails are noted to be dystrophic. The face is normal. Chloasma gravidarum is present. No maxillary prominence or no facial puffiness. The eyes, no abnormality detected. Vision is normal. Pupils are reactive to light. Ears are symmetrical. Hearing is normal. Nose is symmetrical. Nasal septum is normal, and there is no discharge. Oral cavity, their teeth are distributed normally. Absence of dental caries. Absence of halitosis. And there is absence of any lymph node enlargement in the neck. Absence of thyroid gland enlargement. The breasts are slightly.
Would you do a head to toe? Would you present a head to toe in every antenatal case, or you particularly want to do in this case because she's undernourished?
Yes, ma'am.
In this generally, yeah.
Yes, ma'am. It is always a good idea to have a quick view of the head-to-toe examination, but while presenting, I would definitely focus on in an FGR case because we need to find out other signs and symptoms which point out towards undernourished or malnourished, poor dietary intake during her pregnancy. So, ma'am, in this case, her hair, dandruff, scalp is dry, dystrophic nails, all of these point towards macronutrient deficiency, fatty acid deficiency. And yes, ma'am. So in this case, definitely we will go for the examination, head to toe. And the breast and nipples, breast are slightly enlarged. There is slight white discharge from the nipple, and the nipple is normal without any retraction or inversion. The skin, linea nigra is present, stria gravidarum is present, and cloasma gravidarum is present. Extremities, upper and lower extremities have normal range of motion. Systemic examination, cardiovascular system, S1 and S2 are heard, there are no murmurs. The respiratory system, there are normal vesicular breath sounds, bilateral air entry is equal with no crepitations, and the CNS, higher functions are normal with normal gait and balance. On obstetric examination, inspection, abdomen is uniformly distended, longitudinally ovoid in shape, no abdominal wall edema, umbilicus normal and flushed with skin, hernial orifices are normal, stria gravidarum and linea nigra are present. No scars are noted over the abdomen. On palpation, the symphysiofundal height is noted to be 30 centimeters. The fundal grip is soft, broad, and non-palatable, suggestive of breech. Lateral grips, knob-like structures on right side, suggestive of limb buds, and uniform resistance is felt on the left side, suggestive of spine. In the first pelvic grip, smooth, hard, palatable mass is present, suggestive of fetal head. And second pelvic grip, fingers converge, indicating the head is not engaged. The uterus is noted to be relaxed. On auscultation, fetal heart sounds are heard along the left spino-umbilical line. It is 142 per minute, regular and rhythmic. On local examination, external genitalia normal with no vulval, no edema noted. Per speculum examination, cervix and vagina are healthy, no leaking or bleeding per vagina, and per vaginal examination shows a non-dilated and non-effaced cervix.
Why was a per vaginal examination done?
Ma'am, in this case, she is 36 weeks, 0 days of pregnancy, which is she has already reached near term. So we would like to calculate a Bishop score for her, because if we want to induce her further at a later stage, or if we plan to induce her after doing her Doppler examination or anything, we need to know if we have a favorable cervix or not. So for that, we have done a PV examination.
Generally, we do a PV at 37, but you were, without making a diagnosis, I would suggest that PV could have been avoided at this stage.
Yes.
And your SFH was 30, but uterine height in weeks, how much was that? If we talk about the weeks.
Ma'am, it was corresponding to that only. It was 30 to 32 week size using the first fundal grip.
Okay, and did you take the abdominal girth also?
No, ma'am, the abdominal girth was not taken in my case, but just the symphysiofundal.
Yeah, actually, all three things should be taken, because, if your SFH can be low in, suppose it's a transverse lie, suppose, right?
Yes.
So anyways, we take all, you should take, especially in a case of FGR where you're suspecting, take all three and see if they're corresponding. And for the residents, I think they all know that the fundal height in weeks starts to correspond with the period of gestation after 24 weeks of pregnancy, and approximately similar with the symphysiofundal height, whereas the abdominal girth in inches starts to correspond with the period of gestation after 24 weeks. So preferably mention all three whenever you are presenting in OBS case.
Yes.
Okay. So your final diagnosis?
So the provisional diagnosis was made of 24-year-old female with a 36 weeks, 0 days pregnancy in the case of second gravida, with a single live intrauterine fetus in cephalic presentation, with a uterus noted to be small for dates. So the plan for this patient was to have a growth scan with a Doppler at 2 week present at admission and in 2 weeks interval if need required, and we have to analyze the previous USG reports. So which was done for this patient. The previous USG reports at 9 weeks, 0 days, 20 weeks, 2 days, 34 weeks, and 36 weeks were done. Ma'am, at 9 weeks, 0 days, her CRL was 9 weeks, 2 days, on the basis of which we have calculated, which corresponds to the present gestational age.
That is the first thing to be done when you are suspecting growth restriction, that you check the dates.
Yes, ma'am.
Just a second. Vikas, can you check that sir is not able to talk? He's saying to talk. Voice and video are disabled. Is he there?
Wait,
Vikas?
ma'am.
Yeah, please just check. I had shared my link with sir actually for phone, but he was able to do till now.
Done, ma'am.
Okay. Yes, sir.
Now I can hear. Can you hear me now? Yeah. My
Yes,
video
sir.
is muted. Stop now.
Okay, sir. We can hear you, sir.
Okay, yeah. Yeah, I think he had presented the case very well. And so just Dr. Tejas, I mean, how to differentiate between various types of fetal growth restriction and what terminology to be used for it? Like in olden days, IUGR was used, it is not used anymore. I mean, it had to use fetal growth restriction. So why the and fetal growth not retardation but restriction? Why the change?
Yes. So your voice is not clear, but I
Yeah.
understood, ma'am. Sir, fetal growth restriction, how can we diagnose it is what I think. So,
Yeah.
sir, so basically this falls in the category of small for gestational age, SGA. And there are four causes in my mind about SGA. The first is wrong dates, which we have to check with the help of her LMP and her CRL. Then the other is a constitutional small for gestational age that we can we have to see the mother, we have to see the previous child which has been born, her the birth weight, if low birth weight or not, and that is what constitutional SGA is. Then the third cause is if there is any anomaly, any chromosomal abnormality or any infection which can lead to a fetal growth, decreased fetal growth. And the last is fetal growth restriction per se that we call that is a decreased growth potential of the baby when the anomalies can chromosomal abnormal when there is no anomaly, when the chromosomal abnormality is also absent and there is no infection. Then in that case, if there is still a decreased growth potential, then we call it fetal growth restriction. And the most common cause of fetal growth restriction is uteroplacental insufficiency because of various causes. Most commonly, it could be preeclampsia. So, how do we diagnose fetal growth restriction? So, once we have ruled out wrong dates, anomalies, infections, or we have ruled out any chromosomal abnormalities possible, after that, if on per abdo examination, if we find that the symphysiofundal height is 3 centimeters less than what it is expected to be at that week. So, for example, in her case, 36 weeks, and her symphysiofundal height is 30 centimeters. So it's 3 centimeters less. Then that is raises a clinical suspicion, and after that we have to check uh, her growth chart. So as we are seeing in this USG at 9 weeks, she was 9 weeks 2 days. So she's right. Her gestational age is right according to the early trimester scan. At 20 weeks, the GCA, that is a gross congenital anomaly scan, there was nothing noted. There was no GCA. So there is no major anomaly. And she does not have any history of fever, of rash, or any infection in the first or second trimester. And then we note at 34 weeks, 0 days, that only her AC, abdominal circumference, is 29 weeks, 0 days. And at 36 weeks, it is 32 weeks, 0 days. And the effective fetal weight is 1.8 kg at 34 weeks and 2.1 kg at 36 weeks. And if we chart the AC and the effective fetal weight, it comes to less than the 10th centile for that gestational age. We have done that charting here. This chart we have used is an intergrowth chart, intergrowth 21st century chart, which is made along with Oxford University, which we can where we I have plotted at 34 weeks and at 36 weeks, the effective fetal weight is less than 10 centile. And that is a definition of fetal growth restriction, which is that the effective
So,
fetal weight is
we
the
have
is
to differentiate between FGR and SGA.
yes, ma'am.
Oh,
And SGA is when FGR is a specific kind of small for gestational age where the fetal growth potential is not achieved. And we can see that over two readings, which are 2 weeks apart at 34 weeks and 36 weeks, that the AC is lagging and it is less than the 10th centile in two specific readings. So we can find out that earlier there was up till 20 weeks, there was a growth potential which the patient has, which the fetus had. And at 34 and 36 weeks, the growth potential has decreased. So there is a decrease in the growth potential indicating a fetal growth restriction. And that is all the other factors have been ruled out.
So basically, fetal weight or AC less than 10th centile can be, but more than 3rd centile can be SGA if it is not associated with Doppler changes. If
Yes, ma'am.
the fetal weight or AC is less than 3rd centile, it is fetal growth restriction. And if it is between 3rd centile and 10th centile with Doppler changes, uterine artery or umbilical artery Doppler changes, then we call it FGR. So
Yes, ma'am.
between the 3rd and 10th centile, if Doppler changes are not there, and like you explained, the growth, it's just the growth potential that is over or low. So then it is a constitutionally small for gestational age also. These
Yes,
two scans are, I mean, only the AC has increased by 3 weeks, whereas the BPD and HC and IFIL are pretty much the same. I think the quality of the scans might also be questionable. And I mean, you mentioned the NT scan also and this 20-week scan. So any uterine artery Dopplers were done at that time or just
Ma'am,
scan?
yes, the uterine artery Doppler was not done at 9 weeks, 0 days. It was done at 20
No,
weeks, 2
no,
days in
it's
anomaly.
not done at 9, yeah. So it's done at
Yes,
either at the NT scan, the
NT scan or
13-week scan, or the anomaly
anomaly scan.
scan.
So anomaly scan Dopplers were found to be normal. The
Yeah.
entire scan was found to be Doppler-wise also was found to be normal. Yes,
And
ma'am.
whether the dual marker had been done or not,
Dual marker in this case was not done. We did not
financial
have a
probably,
value of
yeah.
PAPPA or beta HCG. No, ma'am.
Yeah. So what are the risk factors in this case that you think that she has a growth restriction? And whether this is the late onset or the early onset growth restriction?
Yes, ma'am. Ma'am, from
First
the
of all,
present.
sorry, do you have the Dopplers for 34 and 36 weeks?
Yes, ma'am, we have. So at 36 weeks, we have the Doppler findings. So the umbilical artery Doppler, SD ratio, and pulsatility index we have. So umbilical artery 2, it's in the 25th centile, SD ratio, and the PI is at the 48th centile. Middle cerebral artery Doppler, SD ratio, 30th centile, and PI is at 42nd. Has it not come on the screen?
No, yeah, now we can see.
Now?
Yeah.
Okay. Yes. So at 36 weeks, we have the Doppler study. The umbilical artery SD ratio is 20 of the 25th centile. PI is 48th centile. Middle cerebral artery is 30th centile and PI is 42nd centile. And the CPR is 1.93. It is more than 1. So from an overall perspective, the Doppler findings are normal. The MCA PI is more than 5th centile, and the umbilical artery PIs are less than 95th centile.
Yeah, and the CPR is more than
And
1.
CPR is more than 1.
Or we can even look for the centile of CPR as well, is more than
Yes,
1
ma'am.
into
Yes,
case.
ma'am. Yes, ma'am.
So then what is your diagnosis and what do you think? What is your
Yes, ma'am.
diagnosis then?
Yes, ma'am. So the final diagnosis which was made is 24-year-old female with 36 weeks, 0 days pregnancy. In the case of second gravida with single live intrauterine fetus in cephalic presentation with late onset fetal growth restriction with a normal Doppler finding.
No, what was the percentile of the estimated fetal weight?
The percentile we had calculated.
It's
I don't
between,
have the value, but it is between
yeah.
10th and 3rd centile.
Yeah, so actually, if it is between 10th and 3rd centile and Dopplers are normal, it's more likely to be SGA. Plus, if you
Yes,
see that the growth velocity has been maintained, the baby is following the same, it hasn't fallen below, right? It is
yes, ma'am.
going up still, so it's remaining up between the 3rd and 10th centile. And so, I mean, what are the risk factors in this case? And then what are the things, how do we predict or what all should be done for screening of FGR at the first booking visit?
Yes, ma'am. So, ma'am, in this case, out of all the risk factors, in this case, the risk factors are first, the patient has a the BMI is 17. She is underweight. That is the first risk factor. The second is that she has a interpregnancy interval of just 6 months. So that is another risk factor in her case. Apart from that, she does not have, we did not have any PA-PPA findings, so that is not there. But she does have low maternal weight gain. For her BMI,
Calorie intake, yeah, the calorie intake is also less in her case, right?
yes, ma'am. Her calorie
There is
intake
a
is less,
deficit.
and her weight gain is also less compared to her BMI pre-pregnancy.
Yeah, so
So these are the risk factors. And ma'am, how do we screen? So the screening of the screening for the fetal growth restriction, it has three parameters. The first is the history, second is clinical examination, and third is the ultrasound findings and biochemical findings. So the history, in the history, we have to ask at the booking and throughout the pregnancy, if her pregnancy is happening at the extremes of age, that is teenage pregnancy or beyond 40 years, if she has extremes of weight, that is obesity as well as underweight, if she is unmarried, because a decreased familial support is definitely the patient has a higher propensity for FGR. If she is a laborer, high vigorous work, intense daily exercise, or if she has any history of addiction like cocaine or cigarette smoking of more than 11 cigarettes per day. Apart from that, if there is any past medical history like hypertension, renal impairment, diabetes mellitus, especially with any vasculopathy, if she has had, if she is taking medication for SLE, or if she has any history of antiphospholipid antibody syndrome. Then in the past obstetric history, if she has preeclampsia in the past, if she had an SGA in the past, low birth weight baby in the past, stillbirth in the past, short pregnancy interval less than 6 months, or even a long pregnancy interval of more than 5 years is also considered to be a higher risk for FGR. And if she has, in the first trimester, she has had any heavy heavy vaginal bleeding, that is also considered to be high risk. And in the current pregnancy, if she has preeclampsia, which leads to uteroplacental insufficiency, if the anomaly scan shows echogenic bowel, then that is a singular risk factor for FGR. If her PA-PPA values, pregnancy-associated PPA values, are less than 0.4 multiples of median, and if she has a low maternal weight gain. So all of these, RCOG had brought out a green top guideline, and these are all the risk factors which they have found out. There are two types of risk factors, minor and major, in the history itself. Then further, after taking such a history, we do her per abdominal examination, in which we have a cutoff of 3 centimeters. That if the fundal height is less than 3 centimeters from her gestational age, then it is considered to be high risk or a red flag for FGR. And then after
further
that,
evaluation.
for further evaluation, yes,
Yeah.
ma'am. And then further evaluation would be three. Then further evaluation would, one thing that we also has to have to do is that we have to see the weight gain chart. If her weight gain is not going according to the trimester, then in that case, that is one another red flag. And then we can go for an ultrasound. An ultrasound, if we find that her effective fetal weight or her abdominal circumference is less than the 10th centile or less than the 3rd centile, then it is considered to be FGR. I mean, between 3rd and 10th centile is SGA, and less than 3rd centile is FGR. So that Delphi consensus was brought out in 2016, in which we had two type of FGRs. There is an early onset FGR and a late onset FGR, less than 32 weeks and more than equal to 32 weeks. So if it is an early FGR that is less than 32 weeks, then the criteria for that is that the AC or effective fetal weight is less than the 3rd centile. That is independent criteria. Or if the umbilical artery has an absent or reversal of end-diastolic flow, or the AC or effective fetal weight is less than 10th centile, combined with a uterine artery PI of more than 95th centile, or uterine artery, umbilical artery PI of more than 95th centile. And then late onset FGR, which is our case, in that the AC or effective fetal weight should be either less than 3rd centile, or two of the following three should be positive. One is that the AC or effective fetal weight is less than 10th centile, or the AC effective fetal weight is crossing more than 2 quartiles in the growth centile. And lastly, CPR, cerebroplacental ratio, is less than 5th centile, or the umbilical artery PI is more than 95th centile.
So in this case, it is SGA or FGR?
So yes, ma'am. According to Delphi consensus, this is a more than 32 weeks. It's a small for gestational age because the Doppler findings are
Doppler's
not.
findings are normal. Yeah. So
Yes,
actually,
ma'am.
uterine artery Doppler would also again, but anyways, the CPR is normal, right? So this is basically SGA, right?
Yes, ma'am.
Okay. So then how will you manage? She's at
Ma'am.
36 weeks.
Yes, ma'am. So, in any case, we have to keep her at a higher index of suspicion for any development of fetal acidemia, etc. So, the surveillance we will have to start from 36 weeks. The umbilical artery PI and MCA PI Doppler will have to be done once in 2 weeks, and NST or BPP will have to be done 1 to 2 times a week, and growth scan will have to be done every 2 weeks. And
So
at
she's
any
already 36 weeks. What do you mean every 2 weeks? We don't have time now, no? She's already
yes, ma'am.
36.
So yes,
So
ma'am.
when do you plan to repeat the next scan?
At 37 weeks, we will do the next scan, growth scan along with the Dopplers, and BPP NST will also be repeated once in the up till 37 weeks. At any point of time, if there is absent or reversal of end-diastolic flow in the umbilical artery, then we will consider termination of pregnancy. And if that is not the case, then in this case, as it is, we will consider termination after 37 weeks of gestation.
In SGA also we will terminate at 37?
Ma'am, in our setup, we had planned for this patient. We had planned that at 37 weeks after that, we will definitely at between 37 and 38 weeks of gestation, we will induce this patient and
Actually,
deliver.
yeah, according to guidelines for an SGA, if you have defined it as an SGA and not an FGR, you can actually go up to 39 also for SGA. That is why we are differentiating between the two types, right? Because an SGA baby is not compromised, but it's just the growth potential is low, right? So actually, according to British guidelines, the RCOG, you can go up to 39 for SGA, but if it is an FGR, then 37 to 37 plus 6 is the maximum that you can go, right?
Yes, ma'am.
So you can repeat the Dopplers in this case at 37 to just confirm that she is still SGA and not FGR, right? And your NST and biophysical at least twice a week can be done. But if there are no Doppler changes, you can still go with the weekly monitoring up to 39 at the most. But then all of that will depend upon patient compliance as well, the kind of setup you have, her Bishop score. So all of these will help you decide, actually make the decision in the practical settings. But definitely not less than 37, definitely no. Okay, so if it was an FGR, then yes, 37 to 38. But now that we are thinking of an SGA, we can go a little farther also.
Yes, ma'am.
Okay. So you can actually repeat a growth scan at 38 weeks and see if there is any interval growth. Because in this case, from 34 to 36 weeks, there was quite good interval growth, almost a 300 grams in 2 weeks the baby has gained, right?
Yes, ma'am.
So, in between early onset FGR and late onset FGR, how is the management different with Dopplers, and how does it progress differently?
Yes, ma'am. So, ma'am, early onset FGR, there is a much more orderly fashion in which the Dopplers change. So, initially, there is only a change in the uterine. So, there is a placental disease. Then, after that, there is a compensated hypoxia. Then, there is a decompensated hypoxia. And finally, there is a serious, uh, some ischemia component has developed in the fetus. So when there is a placental disease initially, only the uterine PIs will get affected, whereas the rest of the Dopplers will more or less be normal. After that, compensated hypoxia, in that there would be changes in the middle cerebral artery, umbilical artery, middle cerebral artery, and so changes in the aortic isthmus can be noted.
The brain sparing effect.
Yes, ma'am, the brain sparing effect. Then then after that there is decompensated hypoxia, where finally the ductus venosus will get affected. And after that, once there is ischemia or serious brain injury, only at that time the CTGs will become abnormal in this patient. So, ma'am, so there is this Barcelona criteria which is being used for staging of early FGR. They're not useful in staging of late onset FGR, in which there are 4 stages: 1, 2, 3, and 4. The first one, when the effective fetal weight is less than third centile, the CPR is less than fifth centile, the umbilical artery PI is more than 95th centile, the MCA PI is less than fifth centile, and uterine artery PI is also more than 95th centile. In this case, we have to do a weekly monitoring and we have to deliver at 37 weeks, preferably by induction of labor. In the second stage, there is absence of end-diastolic flow in the umbilical artery. In the third stage, there can be a reversal of end-diastolic flow in the umbilical artery. And in the fourth stage, there could be CTG changes or ductus venosus changes, reversal of flow in ductus venosus.
Yeah,
So
so
if
basically, if you have an early onset FGR, you monitor by the uterine artery, the umbilical artery, the MCA, rather more important than MCA, the ductus venosus. In less than 30 weeks, the ductus venosus flow is very important for monitoring and deciding termination, especially if the umbilical artery has already become absent or reversed, right? And whereas in the late onset or the term FGRs, MCA and the CPR has a much important role
yes, ma'am.
to decide the termination and the timing of delivery. So ductus venosus becomes is not very useful after the growth restriction is diagnosed after 32 weeks. Okay. And like you said, so which one is the more dangerous one, the early onset or the late onset FGR? Actually, the late onset FGR, because it is unpredictable.
Yes.
Yeah, so the early onset you can monitor and you know that if the umbilical artery flows are okay, things will remain fine. But in case of late onset, there can be bane sparing even in spite of a normal umbilical artery. So you have to monitor both. And it's the CPR now which has to be seen, not just the umbilical artery. Okay. So late onset are actually more dangerous and patient has to be much more careful. And for late onset FGR also, we terminate 37 weeks, at the most 37 plus 6, not later than that, right? But SGA is the only one where you can go further on, depending upon the patient compliance, your monitoring facilities, your NICU, your bishops, and other
I think this,
things.
yeah, I'm back now.
Right.
Japleen. Yeah. So basically, I think that point has been already highlighted, but maybe for the sake of students, I think if it can be cleared that when to induce the stage 1, that when to can we take the patient up to 40 weeks, 39 weeks, 38 weeks, 37 weeks, and even sometimes we have to induce them 34 weeks depending on the Doppler findings. So that part can be clarified again. I think that will be useful for the students.
Yes, sir.
Yes.
I mean,
yes.
if everything is going on fine, like in your patient, it's just mild IUGR only suppose, then can we take them up to 38 weeks or 37 weeks? And if Doppler studies are normal?
Yes, sir. So, in the case of early FGR, we can follow the Barcelona criteria. That depends upon the termination time. The time of termination depends upon what is the stage. So if it is stage 1, that means the umbilical artery does not have absent or reversal of end-diastolic flow. Then it can be taken up to 37 weeks of gestation, and induction of labor is preferred over direct C-section. In the second stage, when there is an absence of end-diastolic flow, then it is, according to the Barcelona criteria, the termination should be at 34 weeks of gestation, and C-section is preferred over induction. When there is reversal of end-diastolic flow in the umbilical artery, which is the third stage of early FGR, then C-section is preferred at 30 weeks. As soon as the patient that the fetus
whenever
diagnosed, 30 weeks. Whenever diagnosed.
But in that case also, suppose, will it be different if you have a patient at 30 weeks, 32 weeks, 34 weeks? You know what, as Japleen said, no role of ductus venosus in that case.
Yeah.
Yes, ma'am. Yes, sir. So, in the third, there are 2 criteria. One is that reversal of end-diastolic flow and ductus venosus PI more than 95th centile. So, if any of these cases are there, if ductus venosus is a much stronger marker and it shows direct cardiac compromise. So, if the ductus venosus is at
Absent
more
or
than
reversal of the A wave of
of the
ductus
A
venosus.
wave, yes, yes, ma'am. So, if there is a reversal of the ductus venosus, then that is directly category 4, and that means that immediate termination is
Like
required.
irrespective of the gestation, irrespective of dexamethasone therapy or not, we have to
Yeah.
terminate there and then. Isn't it?
Yes, ma'am.
But
But
otherwise, if ductus venosus is fine, but there is reversal of end-diastolic flow, patient is say 30 weeks or so. In that case, then we can wait
DEXA
so
cover.
that for the dexamethasone to act. And what is the role of
magnesium.
neuroprotective role of Maxel? Suppose patient is 29 weeks or 30 weeks,
Yes.
reversal of end-diastolic flow, but ductus venosus is not. So I mean, is okay.
Yes, ma'am. Yes, sir. So there is a role of neuroprotection we use for that magnesium sulfate. Magnesium sulfate is given in the it is given within it is has to be given up to the 6 hours from the birth of the baby, and the magnesium has a neuroprotective effect to the hyperstimulation of the cerebral hyperstimulation of the baby, and therefore it prevents the cerebral hypoxia, chances of cerebral hypoxia. So whenever we are delivering an early onset FGR or a early onset FGR, we have to consider neuroprotection using magnesium sulfate, and steroid coverage will have to be done for the patient. And
Less than
yes,
32 weeks.
yeah,
Yeah,
up to
after
32
32 weeks,
weeks.
you shouldn't give.
Yes.
And of course, dexamethasone.
Yeah, dexamethasone present recommendations, ECOG has suggested up to, it can go up to 36 plus 6 weeks of gestation.
But
Earlier it
Japleen,
was
are you
34.
in PGI and in your hospital, Japleen, are you using it like our name? They wouldn't, that only 34 weeks they were giving.
Yes, sir. Actually, guidelines have changed again. Earlier, they used to say that for elective cesarean, also before 39 weeks, you should give DEXA. And for FGR, it was said, like he said, up to 36 plus 6 weeks also you can give. But now there are studies saying that after 34 weeks, if steroids are given, there is long-term remodeling. So cognitive issues have been seen. So then after 34 weeks, so between 34 to 37, you have to discuss with the patient whether you want to try it to reduce the morbidity due to RDS, NICU admission, but at the possible cost of long-term neurocognitive. So actually some maths and language delays were seen in about 8 years of follow-up. So now the guidelines have changed, and after 34 weeks, it's not a routine recommendation.
Yeah, it was not given a name, I
Yeah,
recall. They
it's
would.
now for the last 2 years, I think ECOG brought, so now it's not being routinely given. Earlier, we were also giving for every elective cesarean before 39
What are
weeks,
the recommendations of
but now
RCOG
we've
and
seen.
ACOG and RCOG?
Sir, all guidelines are now saying that if you have, एक तो just in case वाले नहीं देने हैं, that every twins we used to give at 28 weeks, even if there is no chance of preterm delivery. So before 34 weeks also, if you are contemplating possible delivery within the next 7 days, so then you give. After 34 weeks, between 34 to 37, you have to discuss with the patient the pros and cons. You may get some benefit of a reduction in respiratory distress, morbidity, or NICU admission, but it may be at the cost of long-term cognitive
Someone
distress.
had asked at 35 weeks FGR, should we give or not? And some people
No,
think,
no.
it used to be
At
thought that
AEDF after 34 weeks has no role of a conservative management. So here you're not going to wait for DEXA cover.
and DEXA also, no?
Yeah, no steroid here. After
But
34 weeks,
is that true that they tend to have slightly accelerated pulmonary maturity, FGR babies? That concept used to be there, no?
Yes,
But,
that used to be there, yeah.
but before 34
Actually,
weeks,
the
we have
POG,
to
it
give.
depends on the period of gestation. So a similar weight baby, like if you deliver a 1.5 kg baby at 30 weeks due to prematurity, versus if you deliver a 1.5 kg baby who is growth restricted, but the period of gestation is 33 weeks. Because of the period of gestation, the same weight baby will do better. The lung maturity will follow the period of gestation rather the weight. So
It
they are
is
stressed and they have some internal steroids also probably. So they might do better pulmonary wise.
Mhm.
So
Absolutely.
I think,
So the concept should be that up to
yeah,
34 weeks we have to give. After
yeah,
34 weeks for FGR, we don't give steroids
no,
in the exam later variant.
yeah,
And the induction is also very clear that if it is, absent and diastolic flow after 34 weeks, anytime we have to immediately terminate. Otherwise, we can take them up to 38 weeks, 37 weeks, completely. And before 34 weeks, or if there is uh, reversal of end diastolic flow, anytime between 32 to 34 weeks immediately. And before that, then we have to do ductus venosus, isn't it?
yes,
And
sir.
if ductus venosus, that is just to basically to buy time for giving
yeah,
steroids
just the steroid
and
cover. But
and this neuroprotection.
yeah, because REDF will probably not go beyond 1 to 3 days. The mortality rate will be high. So if it is 30 weeks or less, you can use ductus venosus for guiding the steroid therapy.
So ductus venosus is there in guideline. We have to do it, no?
Yeah, yes, sir. In early onset FGRs,
Mhm.
we have to do. And,
And what are the long-term effects, the neonatal and other effects in these children, Dr. Mistry?
Of an FGR patient, the long-term effects, yes, sir. So, in there are three categories: neonatal, infant, and the maternal complications are also noted. So, in neonate, there can be birth asphyxia, hypoglycemia, hypothermia, hyperbilirubinemia, intraventricular hemorrhage, sepsis, seizures, necrotizing enterocolitis, and mortality can because of a low birth weight. And in the infant, an FGR baby as an infant can have neurodevelopmental delays, irrespective of getting steroids. They could have a cognitive delay. Then they might also some have noted childhood obesity to be there in patients who were FGR, delivered as FGR, and even childhood obesity, and it progresses towards metabolic syndrome. And so in the mother also, it has been noted that mothers who deliver FGR babies, in the future, they have a higher risk of early onset preeclampsia and preterm FGRs and future cardiovascular disorders.
yeah, so we used to call it the thrifty gene hypothesis. So an easy way to remember that the baby who is growth restricted in utero, so those genes come up which try to accumulate whatever nutrition they are getting. So those genes, they are chosen, they are selected. So once the babies are born also, and now that they are getting adequate nutrition, they still try to accumulate more. So FGR babies having,
Obesity.
tendency to become obese and
And later
metabolic.
on in middle age, they tend to have more of
Yeah.
diabetes, metabolic syndrome, and all. So
Hmm.
this is called thrifty mechanism or Barker's hypothesis also same.
Yes, sir. Yes, sir.
Barker's hypothesis.
Yes, sir.
I had the opportunity of meeting Professor David Barker from Southampton. He delivered a talk in our hospital, in
Oh, that's
King's
great.
Cross Hospital. But I'm so stupid, didn't take photograph. No, like so should I have mentioned?
Okay, sir.
That's Barker's hypothesis is important, and that probably puts we Indians at higher risk of metabolic syndrome in middle age, and also because possibly like the pancreatic development is not that much, so that's why they are more prone for
Yeah.
developing diabetes also.
Yes, sir.
So anything else left in our case now?
Prevention. Yeah, I think
Prevention, yes,
prevention. Yeah.
prevention, ma'am.
Screening and
A
prevention.
very few interventions are available for as a preventive measure. If one definite source is that is of aspirin. If we have a uterine PI is done at the level of NT scan and the uterine PI is found to be abnormal, more than 95th centile, then definitely starting the patient on aspirin, the dose which is 81 milligram, but we usually at our setup give 150 milligram, that is a twice of 75 milligram dose. It is given up till 36 weeks of gestation. That is the one which can have a prevention of preeclampsia, uteroplasmic insufficiency, and therefore FGR. And there is limited evidence regarding starting any other anticoagulation therapy unless the patient has APLA or SL. And calcium supplementation is there strong. I mean, it's there in Indian setup already, but it helps in prevention of preeclampsia. It has some role. So that is another way of preventing FGR.
And diet and nutrition and
And
regular monitoring.
yes, ma'am. Diet and nutrition and weight gain monitoring. Yes, ma'am.
Right. Okay, good job, Tejas. I think, sir, do you have anything more to add?
Any question from the students? Then we can answer.
There's nothing in the chat box as of now. This was the last
Yeah, but
one.
I mean, they should do
Idiot.
this case very well. I mean, fetal growth restriction case is very commonly asked in
Yeah.
exam. And it's not a difficult case. I mean, if you have to do judiciously, also plus ultrasound findings and various the parameters which you use, biophysical and all that. And what is the monitoring, how often we should do it, how often we should do ultrasound, when we should do Doppler, and what are the findings of Doppler, when to terminate. All this is very, very crucial, very important. So it's not very difficult. I mean, once you understand it, it's quite fairly easy. And role of ductal stenosis, as Japleen already said. So all this helps us in deciding when to induce labor and when to do cesarean for these patients.
Yeah, and one very important thing that practically examiners are very fond of is how do you measure the symphysiofundal height? Because that is the one screening you are using to base your management further. So if you...
Yes,
I think they must practice in the hospital. Maybe Tejas, you want to tell them exactly
yes, ma'am.
how
Yes,
to measure?
Sir. Yes, so symphysiofundal height, the patient is asked we have taken the consent and adequately exposed the patient, or the prerequisites are met. After that, with the help of a measuring tape, we are going to measure it in centimeters, but while measuring, we'll keep the inch side towards ourselves so that we don't manipulate the measurements. We will start, we will start with the fundal grip. We will locate the fundal height and from our non-dominant hand, and with the help of another person, or with the help of the dominant hand, from the upper edge of the pubic symphysis, we will go up to the upper limit of the fundus, and that we will measure on with inch towards our side, and then we will evert it and see the marking in centimeter and find out the fundal.
So actually we call it symphysiofundal, but again you should go from the mobile point to the fixed point. Because again, if you move from the fixed to the mobile point, you may still, try to adjust it a little, right?
From fundus to symphysis.
So you actually fix this point first, you mark this point. So you go from fundus to symphysis with the inch side towards yourself. So both these things will help to reduce any kind of bias or manipulation. Okay, so we call it symphysiofundal, but we actually measure it from fundus to symphysis with inches side on our side. These two things being done to reduce the bias. Position of the patient. Yeah, so when you are marking the fundal height, the patient has her feet folded. So because it has to be relaxed, right? But when you are measuring it, since you may not be able to feel the symphysis, you can ask her to straighten the legs. When you're actually putting the inch. So then it can be a dorsal position.
I think there are no question. I think Tejas has beautifully presented the case, and Japleen has very nicely highlighted all important points and important aspects. And as Japleen said, dear students, in symphysiofundal height, same way, like palpation, abdominal palpation, Leopold maneuvers, etc., are commonly asked in exam. You may think that it's such a simple thing, but you will be surprised to know how many students make mistakes in simple, measurements. And because now this NMC is giving a lot of importance to that every student should demonstrate some skills. So it's one of the simplest skills to be tested in exam. So quite often we go for MD, DNB, DJU, all these, MS exams and DNB exams. So they usually examiners are often asking students to do palpation, abdominal palpation. So that is this very simple trick. You should do it properly, standing properly on the right side of the patient, how much exposure of the patient, ensure patient has passed urine, and do all the grifts properly. Even if your findings are wrong, that is acceptable, but you should do it properly. So please practice it, and same as impingofrontal as Japleen said. So do practice them regularly with your teachers and examiners. And any query you have, then you can ask us also in this, and we'll be very happy to help you. So, but do learn it properly. So
Thank
Japleen,
you
you can
so
give
much,
the
sir, for
final comments and close.
Yes, sir. So you have summarized it really well that for FGR, you have to understand, screen every case at booking by history, and if possible, your dual screens and NT scan, the uterine artery PIs. Then, along with screening, preventive strategies, like Dr. Tejas mentioned. So once it is diagnosed, differentiating SGA from FGR, then in FGR, the early onset and the late onset, and then how to monitor them with the Dopplers. And like sir said, that you have to know how to monitor and when to deliver, and prevention for future pregnancy as well. So I think that's about it. So we can close the session
Yes,
now.
please. Yes.
Okay, Tejas, you have anything left to say?
No, thank you, ma'am.
Okay.
Thank you, sir.
Okay, thank you. Belated happy Diwali to everyone. Sorry.
Happy
Yeah.
Diwali, sir.
Okay.
Diwali, ma'am.
Happy Diwali, sir.
Thank you. Japleen, if you can
Okay.
share this Barcelona guidelines with me also. I'm trying to update my edition of the book, no? Or
Okay,
they
sir.
just have this Barcelona in FGR
Tejas, sir.
chapter 5
Yeah.
just now.
Yes, sir. Okay, sir.
Okay. Thank you then.
Thank you, sir.
Thank you, sir.